Dr. Graham Lloyd-Jones, who's a consultant radiologist from Salisbury Hospital, to join us. He's going to be talking to us about what COVID-19 teaches us about the importance of oral health, and he's going to be discussing the impact of oral health on a range of diseases and also introducing us to the SMILE Oral Care Pathway, which is an oral health quality improvement project that they've been working with at Salisbury. So I'm very much looking forward to this session. Welcome.
Thanks very much, Martin, and thanks for the invitation to come here to speak with you today. Let me introduce you to the mouth, which I think is the biggest gaping knowledge gap in the whole of medicine and healthcare. Think of the amazing things that you can do with your mouth and the range of things. You can breathe, you can eat, you can chew, you can taste, you can swallow, you can speak, smile, laugh, express yourself, kiss, all sorts. But as experts in infection prevention and control, have you ever thought about the mouth as being like an immune organ? And if we don't care for it, our mouth, just like any wound on the skin, is an open wound. I'm not here to talk to you about oral health as such. I'm not an expert in that field. But to point to evidence that poor oral health leads to problems in the rest of the body. And for you to be introduced to this concept that a healthy mouth is an immune organ. It's a defense barrier, physical defense barrier, and a microbial defense barrier. And to a certain extent, we've all got a degree of poor oral health. Gum disease is very common. But as we get gum disease and that change of a symbiotic, beneficial oral microbiome to a dysbiotic state, we increasingly have an open wound in our mouths. You would all take this seriously if you saw it on the ward, wouldn't you? We need to take this seriously too. Later, I'll briefly discuss or introduce the oral healthcare pathway or quality improvement project we've initiated in Salisbury Hospital, which we called the SMILE Oral Care Pathway. But I want to give you some background about why on earth a consultant radiologist who doesn't have a background in oral health is speaking to you today. And my interest in oral health and the connections between oral health and systemic diseases started with this disease that we all want to forget about, but is still causing much trouble, COVID-19. My background is that I'm an educator in the field of radiology in medical imaging, and at the beginning of the pandemic, what I wanted to do was to teach doctors how to make the diagnosis of COVID-19 on the basis of imaging. And you can see here that these areas I've highlighted on this image here, the increased areas of white in the lung bases are areas of lung damage. And this is a pattern of disease which is highly distinct. It's actually quite easy to make the diagnosis radiologically because it's a pattern we don't see in other types of pneumonia. And we see this pattern of bilateral, symmetrical, peripheral, and basal lung shadowing again and again and again. This is completely different from what we see in other types of pneumonias, including viral influenza, that sort of thing. On a CT scan, we see in more detail what's going on. This is a slice through the lungs, and what you can see here, again, is the distribution of disease. What we see here is areas of increased density, where there's areas of white. We call this descriptively areas of ground glass opacification. Ground glass opacification is a descriptive term we use in the context of many lung diseases, but it's the distribution of disease that I want to draw your attention to. You can see it's the back and the bottom, the edges of the lungs that are damaged. So the central part of the lungs, if I can point here, central and the anterior and the upper parts of the lungs are spared. And also, you can see that there are these blood vessels, abnormal blood vessels. Wherever we get this abnormal lung damage, ground glass opacification or consolidation, wherever that happens, we have abnormally dilated blood vessels. This disease is all about the blood vessels. And this is a patient who only has a small area affected. You can see more clearly, I think, what's going on. An area of ground glass opacification with a very, very dilated and clotted, congested blood vessel at the edge of the lungs. So all of the features radiologically of COVID-19 are vascular. And it's important that we understand that this is not secondary to a conventional respiratory pneumonia. These are primary events in the lungs. So simply put, both the distribution and the characteristics of COVID-19 lung disease are vascular. Really, I don't think the word pneumonia does it justice. In fact, I think it's misleading. A better term is perhaps pulmonary vasculopathy, which just simply means it's a disease of the lung blood vessels. So, if that's what's going on in the lungs, what's the mechanism? How does this come about? To understand that a little bit, we need to rewind to how we're infected in the first place, how this virus gets into the body. We know it's the upper respiratory tract, the nose and the mouth that are the initial site of infection, not the lungs. The ACE2 receptor, the cell receptor for the virus, SARS-CoV-2, is found on the epithelial surface in the nasal passages in those cells adjacent to the cells responsible for the sense of smell, between 200 and 700 times more intensely than in respiratory cells. Crucial to our understanding is that the mouth is an important initial site of infection with multiple epithelial cell types in the mouth susceptible to infection and viral replication, especially in the minor salivary glands, which are located over the surface of the tongue, on the inner surface of the lips, on the fauces and the soft palate. And in those initial days of infection, the mouth can be seen as a viral factory, just churning out virus into saliva, to the point that a milliliter of virus will contain 100 million copies. That's, if you think about a teaspoon of saliva, a 5 milliliter teaspoon of saliva will contain 500 million copies. Importantly, high viral load in the mouth in saliva has been established as a predictor of death. It's actually a better predictor of death than the patient's age. And that's independent of nasopharyngeal viral load. So there's something about the high viral load in saliva that we need to account for. We also know that SARS-CoV-2 is found in the gingival crevicular fluid, that's the gap between our gums and our teeth, and it's harbored in dental biofilm over the surface of our teeth, and it also directly invades and infects gum tissues. So in those initial days of infection, we can rightly see that the mouth is a viral factory and a viral reservoir in all those niches in the mouth. So what is the connection between that viral reservoir in the upper respiratory tract, particularly in the mouth, and that vascular disease in the lungs? In answering this question, we need to explain why the upper part of the lungs, the central part of the lungs, are not affected. Influenza can affect any part of the lungs, but what it doesn't do is consistently affect the back and the bottom and the sides of the lungs, where we see that pattern with the vascular disease in COVID. We also need to explain the widely reported histological findings, the autopsy study findings, that what's behind this disease is vascular alterations, highly complicated processes, but involving microvascular damage and thrombosis in situ in the small blood vessels of the lungs. We also need to explain why it's been shown that the upper lobes are not even infected. It's those areas of the lungs, deepest in the lungs, the furthest away from the airways that are affected in those areas of lung damage are demonstrated. We also need to explain the dominant thrombosis, clotting in situ, both on the arterial and the venous side of the capillary bed and the small blood vessels in the lungs. And, importantly, the absence of superadded infection with bacteria and fungus, which is not what you would expect. That's what happens in influenza, but that's not behind the death in most cases of COVID, and that's a surprise. So what is that connection between the mouth viral reservoir and the lungs, thinking of the lungs, the lung disease as a vascular disease? The best explanation that this virus is dominantly pathological via an intravascular route through the bloodstream. And the missing link between the mouth and the blood is poor oral health. Specifically, periodontal disease, that's gum disease, periodontitis, which is severe gum disease. This study showed in a population of people with COVID, those who had X-ray evidence of bone loss due to chronic periodontitis, that's chronic long-standing severe gum disease, there was a huge increase in poor outcome with an odds ratio for death of 8.81. Another study showed that was even greater in people who had clinical evidence of active severe gum disease with an odds ratio for death of 14. So all of this led to publication of a model of disease explaining the potential for overspill of pathological processes in the mouth and the virus or viral elements from the mouth to the rest of the body, which I made publicly available in early 2021. I then teamed up with teams and the experts in the field of oral health internationally, and we formally published a scientific hypothesis, which I'm glad to say is now the subject of an invited scientific review for Spring and Nature, which will be, I hope, published in the next few days or few weeks. So I was thinking simply, initially, nothing simple. But thinking simply, if you have bleeding gums, as many people do, as a sign of gum disease, there's no physical barrier between that pool of saliva and the high viral load in our mouths with the blood. And if the virus, or even parts of the virus, could get across the mucous membranes of the mouth, then there's only one anatomical route that it could take. And that is to go down the jugular veins, which are the only veins that come out of the head, join up in the top of the chest in the supravena cava, and then go through the right side of the heart into the pulmonary arteries. And the anatomy of the pulmonary arteries is important because we have to remember that the lungs, the circulation of the lungs is under low pressure, so it's gravity dependent. The pulmonary artery initially pushes blood upwards, it then divides into left and right, and then it's gravity dependent distribution with those arteries doubling back on themselves, dominantly pushing blood into the highly vascularized parts of the lungs, downwards, backwards, and outwards, exactly to where we see the problems bilaterally, symmetrically with COVID-19. And on arrival in the lungs, in those small blood vessels, the capillaries and small blood vessels in the lungs, there would be interaction with the ACE2 receptor, which is found on the inner surface of blood vessels all throughout the body, including in the lungs. And that would trigger a complex process with deactivating ACE2, increase in angiotensin 2, which is a powerful hormone, vasoconstricting hormone, and it also leads to vascular inflammation and clotting in situ in those blood vessels by a process known as immunothrombosis. So that's clotting, inflammatory mediated clotting. And that would explain why there's a change in COVID from a normal vascular supply where in the periphery of the lungs, oxygen is picked up and taken back to the heart, as in this diagram. And in this diagram, there's arteriovenous shunting, where there's pulmonary vascular congestion peripherally due to that vasoconstricting and pro-inflammatory and clotting in those small blood vessels, and dilatation of proximal blood vessels with blood passing in those dilated blood vessels, both arteries and veins are dilated, passing deoxygenated blood or blood without picking up oxygen back to the heart. And that perfectly explains what we see in autopsy studies. It explains the clinical physiological features and what we're seeing visibly with the radiology. Take a look at this. This is striking that all the risk factors for severe COVID are the same as the risk factors for severe gum disease. And really one way you can look at it is to think of gum disease as being a converging risk factor for severe COVID and the lung disease particularly, maybe even a main risk factor. So in summary of COVID, we can see it as an orosystemic disease, a disease which is triggered by processes in the mouth. And with passage of the virus or part virus, we know it's parts of the virus, elements of the virus. We know this is happening. We know the virus gets around the body in the blood. So, or specifically, we can call it an orovascular-pulmonary disease or an orovascular-pulmonary, even systemic disease. Just to pick that apart a little bit, in a few minutes you're going to be having your lunch, you're going to be chewing your food and drinking, and whatever you put in your mouth, you swallow, and goes into the gut, it's digested, and nutrients are presented to the body via the portal vein, the liver, before going into the heart, into the lungs, back to the heart, and then out to the rest of the body. And in this way, nutrients from our food are delivered, and toxins, anything we give orally, any drugs we give orally are delivered to the body in this way. But there's also scope, potential for substances in our mouth to escape the oral mucosa and to get into the body directly, importantly, without going through the liver. So just coming down via this route that I've discussed to the rest of the body. And we make use of this pathway, this anatomical pathway, in delivery of certain drugs. For example, in the setting of angina, a patient with chest pain, they'll just a quick squirt of GTN under the tongue, and that provides the best or quickest route for that molecule to be absorbed across the oral mucosa and to be delivered to the coronary arteries. The same anatomical route is at play in infective endocarditis, so people with poor oral health. Specific oral organisms can get into the bloodstream and circulate and infect heart valves in susceptible individuals. So this is what happens if you have, dominantly what happens if you have a healthy oral mucosa. And to an increasing degree, this is what occurs with increasing damage to your oral mucosa or the immune defense mechanism we have in our mouth, potentially allowing overspill of pathogens, toxins, inflammatory mediators directly into the bloodstream, bypassing the filtration of the liver and causing trouble elsewhere in the body. So the question is, if this is potentially what's happening in COVID, what's the evidence for this happening for other diseases? You may be slightly alarmed to learn that simple things like brushing your teeth and chewing result in a detectable bacteremia of oral organisms for a few minutes. And that's heightened and prolonged if you have gum disease. And there are specific oral organisms that we need to worry about. It's a bit difficult for me to see, but how many people here have heard of Porphyromonas gingivalis? I can see 1, 2 hands. Oh, thank you, putting the lights up. So a few of you, a small number. It's important, I think, that all of you learn about this organism, because as a doctor who doesn't have a background in oral health, looking into the evidence about what's going on and what COVID has taught me about the mouth and the rest of the body, I think that this organism is potentially the most pathological organism known to humanity, and most doctors have never heard of it. This organism is a keystone pathogen in the setting of gum disease. It changes and orchestrates other oral microbial microbes to change the environment of the mouth from a commensal, beneficial environment, symbiotic environment, to away from an aerobic to an anaerobic, pro-inflammatory environment in the context of development of gum disease. But this organism doesn't stay in the mouth. Just to give you some examples. In rheumatoid arthritis, Porphyromonas gingivalis, the DNA of that organism is found in the synovial joints, inflamed joints of those patients. It's an organism which we know is capable of altering proteins and peptides, presenting an antigen to which the immune system responds by producing the hallmark antibody at the core of rheumatoid arthritis, the anti-citrullinated PEP protein autoantibody. And the worse your gum disease, the higher the level you have of that autoantibody. You could say that actually when we're doing blood tests for rheumatoid arthritis, what we're really measuring is how bad your gum disease is. So it shouldn't be a surprise that increasing numbers of studies are showing that if you treat people who have rheumatoid arthritis, treat their gum disease, they have a better outcome in terms of symptom scoring and even blood test markers, inflammatory markers. And there are multiple studies showing this now. The same organism, Porphyromonas gingivalis, is found in the brains of patients and cerebrospinal fluid of patients with Alzheimer's disease. The organism produces toxic proteases, which are enzymes which damage nerve cells. These are called gingipains. And the higher level you have of these in Alzheimer's disease, that correlates with other factors relating to severity of disease. In animal models, mice who are fed Porphyromonas gingivalis, that results in colonization of the brain and laying down components of amyloid, the abnormal protein behind, or partly understood to be behind what's going on with Alzheimer's. Those who have severe gum disease at an outset of diagnosis of Alzheimer's disease have a much more rapid decline over a short period of time, even 6 months, as was found in this study. And importantly, dental treatments improve outcome in terms of quality of life. This is not just in terms of well-being and a sense of dignity. This is in terms of improvement of functional impairment scoring resulting from cognitive decline relating to Alzheimer's and comorbidities relating to Alzheimer's. There's strong epidemiological evidence that severe gum disease is predictive of future onset of cardiovascular disease, and this is thought again to be related to the translocation of oral organisms across the breached immune defense systems of the mouth. Porphyromonas gingivalis, that same organism, embeds itself in our endothelium, in the inner surface of our blood vessels, and is found in atherosclerotic plaques. Again, in animal models, it accelerates formation of those atherosclerotic plaques, induces fatty streaks and aortic and coronary lesions. And treatment of gum disease, effective treatment of gum disease, can reverse platelet activation, reduces autoantibodies related to cardiovascular disease, and normalizes abnormal lipid profiles. Successful periodontal therapy also reduces blood pressure. Other oral organisms are also found in the blood clots, the thrombi of patients who've had myocardial infarction, and are thought to play an important role in inflammation and instability of those clots in the triggering of myocardial infarction. This study was published earlier this year. It's a simple study where they followed a group of patients taken from the outpatient setting, some from a cardiac clinic, some from other settings, and just followed their personal oral health. They found that there's a 51% in reduction in mortality in those who have basic, everyday oral health care. This is stuff like brushing your teeth a couple of times a day and flossing. Last year, I was delighted to be invited to join as a founder member of a task group led by the FDI, the World Dental Federation. And the initial plan was to take the existing evidence for the connections between poor oral health and systemic diseases and present them for the educational benefit of dentists. And the disease for which there is the greatest epidemiological evidence for connections between poor oral health and systemic disease, and particularly gum disease and systemic disease, is type 2 diabetes. And this is our statement. We highlight that periodontitis, that severe gum disease, is a significant factor for future development of diabetes and worsening. So it's not just cause, it's worsening as well. And we point to evidence saying that successful treatment of gum disease improves outcome in terms of getting on top of those glucose scores, HbA1c and plasma glucose, and also has a beneficial effect for vascular, renal complications, systemic inflammation, and quality of life. There are multiple mechanisms at play in type 2 diabetes, with oral organisms now thought to be responsible for inducing insulin resistance. But again, that organism, Porphyromonas gingivalis, is known to reach liver cells where it also alters our hepatic storage of glucose, increasing blood glucose. Interestingly, we also know there's a bidirectional link between those in those who have periodontitis and diabetes. If you've got severe gum disease and you've got diabetes, you treat the gum disease, the diabetes gets better. If you treat the diabetes, the gum disease gets better. And all of this and the concept of the mouth acting as a source of pathogens and toxins or inflammatory mediators overspilling from the mouth to the rest of the body via the blood would explain the increasing evidence there is for multiple systemic diseases being now related to gum disease. By this, I mean that these diseases, important diseases, are in some way either caused or worsened or prolonged by the presence of gum disease. So in all of this, when we're considering the concept of oral systemic diseases, there are important educational messages we all need to learn. And this is a relatively new field. It's certainly new to me. Politicians need to be made aware, dentists, doctors. I'm just going to focus on a few. Hospitals need to invest in best quality oral hygiene and healthcare for all our patients in every setting. And in Salisbury Hospital, we've initiated this oral healthcare quality improvement project, which we've called the SMILE Oral Care Pathway. We've got a long way to go, but underlying it all is this philosophy that we're linking oral health to systemic disease, to general health. We are putting in place specific guidance for specific patient groups in specific clinical settings. We've got a long way to go. One of our pilot projects was with our COVID-19 patients. This is publicly available guidance that we give to all of our patients on a laminated sheet. You can look it up at Salisbury Hospital website and just search for COVID-19 mouth care. It's really just basic stuff, explaining the importance of keeping well hydrated and brushing teeth. And we also prescribe an antiviral mouthwash against SARS-CoV-2. We do that on the basis that there's been a lot of studies, a lot of evidence to show that there are specific mouthwashes which completely eradicate the virus in the test tube and reduce viral load in the mouth for a prolonged period of time. And this is important, and there's also evidence of clinical benefit. As you can understand, if we understand that the mouth is that site of viral factory and viral production, viral replication, and reservoir. This study showed that if you give acutely unwell hospitalized patients with COVID-19 a mouthwash which is active against SARS-CoV-2, they go home quicker, so an average of 4 days rather than 7 days. This was a group, in two groups, they both got mouthwash, one with an active ingredient, one with a placebo mouthwash with no active ingredient. In the active group, with the active ingredient, no one went into intensive care and no one died. In the group in the placebo group, where they were receiving a non-active mouthwash, 28% went into intensive care and half of them died. At Salisbury Hospital, we prescribe a specific mouthwash. Bear in mind, it's not any old mouthwash that does this. We prescribe a mouthwash containing cetylperiodone chloride, which is CPC. It's probably in about a quarter or third of mouthwashes available. And we do that on the basis that it's shown by this systematic review that it's most beneficial in terms of reducing viral load in vivo in the mouth for a prolonged period of time. And it's cheap and it's safe. So for you as specialists in the field of infection prevention and control, you have a crucial role, as we've heard earlier, highlighting the importance of oral health care in a hospital setting. But to ensure that all of your patients, in whichever setting you work in, have good oral health care. When we were starting, we started by doing an audit, and to our horror, we found that 37% of our inpatients didn't have a toothbrush with them, and they didn't know that they could ask for one. So we knew pretty quickly that we needed to do better. And I think a useful concept for you to share is this idea that the mouth is like an open wound on the skin. The inlet is different from the rest of the gut. And it's also important for you to be aware of the really established evidence that paying attention to oral health care in the hospital setting and in other settings is beneficial. Simply put, if you pay attention to oral hygiene in inpatients, they go home quicker and they die less. And I think that the public really need to be informed about the emerging evidence, increasing evidence, overwhelming evidence, in my view, of connections between poor oral health and development and worsening of systemic diseases. I think that we live in the dark ages when it comes to our understanding of how important the mouth is and oral health is for overall body health and how long we live. And just as in 1854, John Snow unveiled that this pump in Broad Street was the source of an outbreak of cholera, so too we can now think of the mouth as being a source of disease, passing from the mouth with pathogens, toxins, inflammatory mediators, not passing through the streets of London, but passing through the streets of our body, our blood vessels. I think we may even need to think about a new public health campaign. Gum disease kills. This is true for COVID, it's true for multiple diseases. But I know that I understand this is a problematic public health message, and nothing is ever that simple. But we do need to make the public aware, and hopefully all of you are aware now, of how important looking after the mouth is. So what does COVID-19 lung disease teach us about the importance of oral health? From my perspective, starting by trying to learn about this disease from a radiological perspective, we can deduce that COVID-19 is all about upper respiratory tract infection with dominant pathological processes involving blood distribution via the bloodstream on oral vascular disease and oral vascular systemic disease, which is also the case for long COVID. And then from that, we can think of these diseases for which there is abundant evidence now that a similar anatomical route is at play. I think one way that we could think about these diseases is to think of rheumatoid arthritis as gum disease of the joints, Alzheimer's disease as gum disease of the brain, diabetes as gum disease of our glucose metabolism, cardiovascular disease as gum disease of our blood vessels, and there are other diseases I haven't mentioned. Huge links between poor oral health and chronic kidney disease, inflammatory bowel diseases, even cancers, and multiple other diseases, many of which we currently consider idiopathic, of unknown origin. And all of this comes about by failure of that important immune defense barrier that we have, that's conferred by loss of our biodiversity, our commensal beneficial microbes, and narrowing of that biodiversity of our oral microbiome, and in the setting of development of gum disease and breach of that physical barrier. And what we don't really have time to go into is the bigger picture of the effect of diet, poor diet, smoking, vaping, and poor oral hygiene. And of course, even bigger than that, the context of socioeconomic class, which affect all these things, and lack of access to dentistry. So this is a sort of take-home concept I want you to go home with, that your mouth is not just for singing and eating and chewing and tasting and smiling and kissing. We should see the mouth as an important immune organ in the body. So how much is your mouth an open wound? How much is your mouth and the mouth of your patients an open wound? Your mouth is amazing. So look after it, don't take it for granted, and I hope you enjoy your lunch. Thanks very much.